Good evening, everybody, to the weekly Thursday University of Miami Cerebrovascular and Skull-Based Symposium. This is session number 8 for us for these Thursdays, today on July 9, 2020. I am Welch-Morcos, professor and co-chair of the Department of Neurosurgery and Otolaryngology and director of Cerebrovascular and Skull-Based Surgery. I am delighted to have in this course as co-directors Carolina Benjamin, who is director of our Keynes lab and specializing in brain tumor and skull-based surgery, Michael Ivan, who is a director of research Brain Tumor Initiative, specializing in brain tumor, skull-base, and epilepsy surgery, Robert Starke and Eric Peterson, my endovascular, open vascular colleagues, and also Bobby Starke is today one of our panelists as well, and director of endovascular research. As every Thursday, we of course broadcast to you from beautiful Miami, Florida. This is our medical complex. These are our two main hospitals, University of Miami Hospital and Jackson Memorial Hospital. Naturally, we're a tertiary or quaternary referral center for many complex neurosurgical diseases, including, of course, cerebrovascular and skull base, which is why we decided to start this weekly Thursday symposium. This is when we started back May 21. These are the lectures, the sessions that have happened already. Today we are here at session 8, and when you can go on our website and see what's coming up, but all these lectures and sessions well into September have already been finalized, and I'm working on a few more months after that. To give you an idea what is coming next week, please join us if you're interested in cavernous sinus. We will have Laligam Shekhar and Ricardo Ramina talking about cavernous sinus surgery, on general cavernous sinus surgery, as well as trigeminal schwannoma, with an excellent group of panelists, international panelists, Tiet Matheson, Torsten Melling, Sean Raza, and Georgios Zenonos. Alongside these Thursday conferences, my partner, Mike Ivan, has been doing a very successful Wednesday series, the Miami Global Brain Tumor Symposium, which is a mixture of intrinsic and extrinsic and skull-base brain tumors. Next week, I am sure you'll be very interested in Juan Carlos Fernandez Miranda, who's going to talk about endoscopic endonasal surgery for chordomas, chondrosarcomas, surgical anatomy, and technical nuances. Please join us for that session and every Wednesday session if you can as well. Many thanks always go to our wonderful team here at the University of Miami, Ingrid, Roberto, Cristina, and of course Ignacio, who is actually running this webinar. You can read more about our educational offerings through this website, our website, in that yellow box. You can email Ingrid, her email is there. You can certainly contact me by email. You can see me on Twitter as well, where I make some announcements regarding these sessions and others. And we have a departmental Instagram and Twitter as well. Housekeeping instructions, please. I know you will have questions. Type them in the Q&A box at the bottom of the Zoom screen. And that's probably the most interesting part of the whole evening, is to discuss your questions with our panelists and speakers. We do not offer CMEs. Please tell your friends and colleagues through social media if you like these sessions, encourage them to attend. I've asked our two speakers to each give 25 minutes. I'll give them a brief reminder 2 minutes before the end of their 25 minutes. Let me introduce our panelists, and we have 4 superb panelists today. Aaron CohenGadol, who I doubt needs any introduction. Aaron has to be credited with international neurosurgical education. His website, the Neurosurgical Atlas, is by far the most popular educational online tool worldwide, ahead of the big societies, and for good reason. He spent, as he will certainly tell you, more than 10 years putting a beautiful product together. And I'm sure if you're here, you already know about what the offerings are. And I'm delighted Aaron is joining us today as a panelist, as a cerebrovascular and skull base expert.
Thank you, Jacques.
You're welcome. Amir Dehdashti, who may still be operating, but he promised me yesterday that he will try to join us. Again, wonderful cerebrovascular skull base specialist at Hofstra Northwell in Manhasset, New York, originally Iranian, went through Switzerland and did a fellowship in Toronto and ended up in Manhasset, New York. We'll see him a little later. Bobby Starke, my spectacular younger partner, spectacular endovascular, open vascular, extremely prolific writer. Just a couple of years into he being a faculty, has published more papers than probably 95% of the neurosurgical realm in the world. Bobby has many qualities, but that's for another session, and he's going to have to pay me a lot more to say more about that. But Bobby has been a spectacular partner, and thank you, Bobby, for joining us for your wisdom about paraclinoid aneurysms today. Babu Welch, a friend for many, many years, current chair of the CV section. He's a Duke Sampson professor of neurosurgery at UT Southwestern. Babu and I go back a long way through particularly the CV section, also dually trained neurosurgeon who has mastered both the endovascular and the microsurgical techniques, and of course, a wonderful good friend of mine who I haven't seen in a while. So Babu, thank you for joining us and getting into this debate, hopefully later today.
Good to be here.
Thanks. Okay, on to our speakers. Jorge Mura, professor of neurosurgery, Department of Neurological Sciences in Chile, in Santiago. You can read the name of his hospital in Ascencio Providencia. He was born in Valdivia, Chile. Actually, Jorge, one of my relatives emigrated to Valdivia like more than 100 years ago, I discovered. Got his MD in University of Chile, Santiago in '95, residency at the institute where he is now, back in '98, summa cum laude, fellowship in Sao Paulo with this gentleman, Evandro de Oliveira, CV and skull base. He created the first fellowship in his institution back in 2002. He has trained more than 30 fellows to date. I congratulate him for being elected president of the Chilean Society of Neurosurgery starting next year. I'd like to let you know that he has a dog named Dolenk, so that might give you a glimpse into his inner psyche, which we will discuss perhaps later. He has performed more than 3,700 brain surgeries, of which 1,600 are cerebrovascular, and he must have one of the largest paraclinoid clipping aneurysm series in the world, with about 400 of them. He's performed about 150 bypasses. I first met Jorge as a resident in the late 90s when I was a visiting professor. Back then he had a ponytail. His appearance has changed a little bit over the years, but not his passion for what he does, not his passion for teaching, for defending his argument, his points. You can see some of the pictures in the various places around the world where he teaches, and his fellows and trainees really just love him because they can read his heart through his mind and through his passion. And he tends to be quite philosophical at times, but clearly a spectacular surgeon. And next, but certainly not least, is my, again, friend of many, many years, and who almost ended up in Miami back in the 90s. And he should have ended up in Miami and be my partner many moons ago. And that's our fault and our mistake. Giuseppe Lenzino, professor of neurosurgery and radiology at Mayo Clinic in Rochester. Giuseppe is probably the best example of why this country needs quality immigrants. Giuseppe is just simply a spectacular person at all levels, cognitively, technically, temperament-wise. You can imagine how much this country would be poorer they did not have this choice of the best coming from all over the world. And Giuseppe is a quintessential example of that. He did his MD University of Bologna in Italy, summa cum laude, residency University of Virginia, fellowship in endovascular in Buffalo with Nick Hopkins, and then a fellowship in Phoenix with Spetzler in vascular and skull base. Again, I mean, he's gone to the best. He is absolutely a prolific writer. He's got more than 600 quality publications. There is no garbage. Giuseppe does not publish garbage at all. Every paper he's involved in is very thought out. I don't know when he sleeps. He published 3 books as well. So you can see it's a fantastic panel today, and I'm going to stop speaking, and Giuseppe, please unmute yourself and share your screen so you can start.
Jack, thank you very much for the invitation and for the very kind introduction. So my role today is to support the utilization of flow diversion for paraclinoid aneurysms. Flow diversion was really created for paraclinoid aneurysms. Unlike other aneurysms, they are sidewall aneurysms. And the idea about flow diversion is by placing a flow diverter and therefore redirecting flow away from the aneurysm back into the parent artery, you create a situation of relative stasis inside the aneurysm, which is a closed pouch. And over time, that stasis progressively create thrombosis and obliteration of the aneurysm. So the theory behind it is very appealing, and it actually works. This is a middle-aged woman with very minimal symptoms, some floaters, probably related or even unrelated to this large paraclinoid aneurysm, and this was treated with flow diversion, and now we're used to this beautiful picture of the follow-up at 6 months with the disappearance of the aneurysm and the preservation of the parent artery. When we look at data, I think that the most compelling data supporting the use of flow diversion for paraclinoid aneurysms are the data from the PAF study. The PAF study was a multi-center study done between 2008 and 2010, and eventually led to the approval of the device in the United States. 108 patients with 109 large and giant paraclinoid ICA aneurysms, so fairly complex aneurysms. The mean size of the aneurysm, mean diameter, was 18.2 millimeters. The results of the PAF study: 87% occlusion at 1 year, 91% occlusion at 5 years, 5.6% incidence of major ipsilateral stroke or death, no delayed hemorrhagic or ischemic events beyond 6 months. And again, the cases were done more than 10 years ago, and since devices, techniques, and our understanding, of course, has progressed even more. When we discuss about treatment options for intracranial aneurysms, it's also, we cannot forget the fact that the concept of morbidity itself has changed. When I started neurosurgery in the late 80s, the concept of morbidity was all about the focal neurological deficits. But today, morbidity is related to peri-procedural or post-procedural headache. And rightly so, I would say, patients, they like to go back to a normal life as soon as possible. So I think that especially when we compare endovascular techniques to open surgery for brain aneurysms, we must keep in mind that when we consider the morbidity of a treatment, we refer to modern definition and the modern patient and family expectations. What happens to the aneurysm after angiographic obliteration following a flow diversion? Well, as we have lived through the design of flow diversion, it was nice to see how there was a close connection between the theory, what we saw in the experimental lab, and what then happened in a clinical experience. A lot of the studies, experimental studies, which led to the development of flow diversion actually were done here at Mayo Clinic in David Kelm's lab. And in the rabbit aorta, David's lab team was able to demonstrate that after you implant a flow diverter, because of the high metal ratio, the flow diverter induces thrombosis of the aneurysm. And over time, the thrombus acts like a scar, and as any scar, the thrombus eventually retracts, leading to shrinkage of the aneurysm. And that's actually what happens in a clinical arena. This is one of the earlier patients that we treated in 2009, lady with ophthalmoparesis and this large cavernous sinus annulus. This is the 6 months of follow-up with the very small residual. And this is the pipeline device. And more importantly, this was the original MRI with the aneurysm and some mass effect on the pituitary stalk. And you can see that 6 months, along with the obliteration of the annulus, there is a shrinkage and really disappearance of the annulus with the resolution of mass effect. This is an even more impressive case of this lady with this giant, mostly thrombotic cavernous sinus aneurysm treated with flow diversion. And you can see at follow-up progressive shrinkage of the aneurysm. And this is the pre and the post in the same patient. Now, when we think about paraclinoid aneurysms, the question that often comes up with endovascular treatment, but also surgeries, what are the visual outcomes? And this meta-analysis in Neurosurgery Focus in 2017, I think summarizes the overall results by comparing surgical series, endovascular series using coiling alone with or without stenting, and then flow diversion. And in many studies, the visual improvement was 58% after clipping, 49% after coiling, and 71% after flow diversion. When we consider visual worsening, then the data in that meta-analysis were about 11% after clipping, 9% after coiling, and 5% after flow diversion. As we started using flow diverters, the questions were, what happens to the aneurysm after you show complete obliteration? Is that result stable over time? And you place these devices that have such a dramatic effect on flow hemodynamics, and what are the long-term effects of just having a device within the vessel? I think now we have very robust data to be able to say this is the patient I showed before, and this is the 5-year follow-up. And this data come primarily from a 3- and 5-year long-term follow-up of patients enrolled in the PAF studies that basically have shown that overall, in terms of major complications, what you see at the 6 months to a year follow-up, it's what tends to happen over time. Again, we are focusing on paraclinoid aneurysms. When we think and we discuss about flow diversion in other vascular territories, then everything is different. Complication rates, it of course gets much higher. Another question was, what is the fate of side branches in the case of paraclinoid aneurysm, particularly the ophthalmic artery, or even more importantly, perforating vessels that are covered by the device? And if we consider the ophthalmic artery was this other meta-analysis just published, over 900 carotid ophthalmic artery aneurysms where the ophthalmic artery was covered, 85% rate of complete aneurysm occlusion at follow-up, and 3% new visual symptoms potentially related to coverage of the ophthalmic artery. And I like to point that many of these visual symptoms often are episodes of amaurosis fugax without any permanent dysfunction. So it is fairly safe in the vast majority of patients to place these devices across a side branch or even across a perforator. As far as the perforating vessels, again, a very nice correlation between the experimental data and what we have seen in the clinical experience. What happens basically to the perforating vessels, as long as there is a pressure gradient, those perforating vessels, they tend to stay open. And this, again, experimental data from David Kelp's lab. This is the rabbit aorta. And some of the intercostal arteries have a caliber that approximates the caliber and also the angle of origin of human perforators. And basically what Dave was able to show is that you can place up to 3 overlapping devices across the ostia of these vessels. And you can see here in this explant, those ostia, they tend to stay patent. And the reason is that there is a pressure gradient. These are end territory vessels, and that pressure gradient keeps those vessels usually open. Like anything we do, there are complications. I will not go. I presented the past data that specifically apply to paraclinoid aneurysms. And the complications for flow diversions are essentially ischemic and hemorrhagic. I'm not too worried about ischemic complications. Why? Because the vast majority of ischemic complications are peri-procedural. And if we have time, I can go on about the protocol we have developed over time, and we have been able to virtually eliminate short-term ischemic complications. For a long time, the Achilles heel of flow diversion has been the hemorrhagic complications. Why? Because they are delayed and because they can be random. And among the complications, hemorrhagic complications, delayed aneurysm rupture, it's something that it's always important to keep in mind. It's also important to realize that it is almost exclusively a complication that we see in very large or giant and usually symptomatic aneurysms, which by definition are already unstable. Why we see these delayed ruptures? Well, there are different speculations, and could be related to too much thrombus that forms inside the aneurysm too quickly, and that can lead to inflammation, or could be related to a sudden alteration of flow dynamics into an aneurysm that is already fairly unstable. I will not go into the discussion about coil, whether or not adding coils decrease the incidence of these complications, but it is my impression that over time, as we have learned more, these delayed hemorrhagic complications, either related to delayed aneurysm rupture after flow diversion or related to ipsilateral distal intracranial hemorrhage in patients on dual antiplatelet therapy. It is my impression that have become much less common than in the earlier experience. Now, of course, the title of my presentation is intends to be a provocation, but really when we deal with these complex problems, it's important to consider all the options that we have available. There are other endovascular options. There is always the surgical option. And this is a case that one of the earlier cases, I think around 2010, so 10 years ago. In this patient, a middle-aged man with this symptomatic giant, mostly thrombosis, cavernous sinus aneurysm, it was not very easy to cross the aneurysm. Of course, we could have tried and probably would have been successful in going across the neck and deploy a flow diverter. But the point here is that in these patients, we knew that had already passed the balloon test occlusion. The aneurysm was a formidable aneurysm, and therefore, keeping in mind the very traditional but effective options for cavernous sinus aneurysm, parent artery occlusion, that's what the treatment we resorted in this patient with an excellent clinical. And you can see here the 3-year follow-up MRI showing a partial shrinkage of the aneurysm. So as we try to limit complications, which is key to success, never forget the options. And of course, flow diversion, it's not the only treatment for paraclinoid aneurysms, but I think it's definitely today the treatment of choice for the majority of complex paraclinoid internal carotid artery aneurysms. It is extremely important to understand we tend to focus both on the endovascular and the surgical side. We tend to focus so much on the technical aspects, but we forget, and this is particularly true for endovascular treatment, that the key to success, it's really a peri-procedural care, close follow-up. And by using good judgment and choosing the correct option in the individual patients, the rate of complete occlusion after flow diversion is very high, and the complication rate can be kept low and under control. And I thank you for the invitation, and I look forward to the discussion.
Thanks, Giuseppe. That was well ahead of time. You're always on time. Thank you very much for this wonderful review. If you don't mind, stop sharing your slides, and Jorge will share his.
It's okay?
Yes.
Yes. I start?
Sorry?
Start now?
Yes, please, go ahead.
I need to put my, you know.
You want me to reintroduce you again? You liked it so much?
I don't know how to, what I must say after I heard Professor Giuseppe. Then for me, it's a great honor to be here with you, and I want not take more time than I was assigned today, because always Jack said to me that I take so long, and then today I will try to do my best to be inside the time. And this is my conflict of interest. For me, it's a great honor to be here with Professor Lenzino talking about the management of paraclinoid aneurysms. Even Jack put one against the other. I have the lucky to knew him in person, because I knew him, of course, before because of his name, but I knew him in person in Italy. In 2018, we went to a Basilicata conference. It was very nice for me. I knew him, I knew Shubin, and here you can see the picture that I'm always underdressed. It's typical in me. Everybody is very elegant and with a shirt, but I'm sorry, like today I was working in the hospital. And this is my professors from Chile. And I want to say to you that in the right is Dr. Loaiza, in the left, Dr. Ruiz. Dr. Ruiz is still working, Dr. Loaiza is retired. But one of my colleagues' residents in 1997, he made this very, very nice, interesting design. And you can see the fight here between Dr. Loaiza and the endovascular guy. The endovascular guy is Dr. Badilla, but you know, his name is Lautaro Di Guglielmo because of the GDC, you know? And Target Therapeutics was the label at that time. And Dr. Loaiza is Evandro de Loaiza because of my professor. And you can see the ear here. I don't know who is this one, maybe from Badilla, I think, because it's big. But I think that today, what we try to talk to you is we don't need to fight. Yeah, even the title of my conference was this: I am the only one who can resolve the problem of the patient with the paraclinoid, or Professor Lenzino is the only one. I think we can work together. I think we must work together. And when I was in Brazil, everybody knows Dr. Evandro, but I want to talk a little bit about Elder Dehdashti. He's one of the best surgeons I ever seen in my life. He teach me a lot. And when you work with a professor in a fellow, the most of the time the professor is not the only one who teaches you. It's very important. The teaching process is not only for one person. It's a team. It's very important. Everybody must try to teach. The teaching is the future. It's the only way. And for us, the neurosurgeon, the neuroanatomy is very important. I was very lucky because I knew Wen Hung Su, one of the best fellows from Dr. Roton, who is Brazilian. And he teach me a lot about anatomy. He showed me everything. I was very, very lucky to know him and spend time with him in Brazil. And when I start to work in Chile, when I back in 2000, I came to my hospital and I went to a congress and they said the end of microsurgery. The first thing I saw was the end. Then I want to start operating and everybody said, no, this is the end. Because the endovascular is much, much better. You need to stop operate because we're gonna study the ISAC who stopped because of ethical reasons, because the endovascular is much better than surgery. Now we have 18 years from that point and we are still operating and the endovascular are still treating patients. And then it's not the end, I always heard the end of the thing, but after 18 years, the end is not coming yet. We keep going. Because today I want to talk to you about, we have two diseases. One disease is the Raptor Aneurysm, subarachnoid hemorrhage, and one, the unraptor. In the case of paraclinoid, the unraptor ones, the problem is the optic nerve. The optic nerve is not a nerve, it's like the spinal cord. And then when the people talk about endovascular treatment and the success of the pipeline and everything, they talk a lot about the intracavernous aneurysms because of the sixth nerve, the third nerve. But this is not the case. The optic nerve is different. And the surgery is the only treatment that have very good results in order to give you a useful optic nerve. And then we were cited in the stroke guideline of subarachnoid hemorrhage. We can see the experience in the subarachnoid hemorrhage of the Japanese. The BRAT study, I showed you this because we have a letter from Raimond to criticism against the BRAT. And you must remember in 2002, when the ISAT came, all the neurosurgeons brought a lot of letters against the ISAT. Now the endovascular are writing letters against the microsurgery. Then the microsurgery is not dead. The ARETA study, it is a very interesting study about recanalization after endovascular treatment of intracranial aneurysm. It's a French one. It's very good because show the complications in a large series of the French people who have a huge experience in endovascular treatment. And then, like Giuseppe showed, the endovascular have complications because the thing is, you don't open the head. Because you don't open the head, the complications are less. But this is not the problem. The problem is not open the head. The problem is the result. And then when you talk about paraclinoid, you need to give proper definition. You cannot put the intracavernous aneurysms together with the paraclinoid. It's the same case that if you put the anterior fossa meningiomas and you put the olfactory groove with the tuberculum sella, are completely different, because the tuberculum sella, the optic nerve compromise is worse, and then the surgery must be designed in order to decompress the optic nerve. For me, the paraclinoid aneurysms is the same. These aneurysms are meant to manage the optic nerve, and your surgery must be to manage the optic nerve compromise. When you have compromise of the optic nerve, for me, surgery is better. And then you need to know the anatomy for this. The anatomy for this is the roof of the cavernous sinus. You only need to know the roof, the Dolenz or Hakuba triangle. You need to expose the clinoid segment of the carotid artery, because if you expose the clinoid segment, you have proximal control, you can release the optic nerve, you can release the ophthalmic artery, you can release the ophthalmic segment of the carotid artery, and you can release the third nerve. It's very important, even for the PCOM, where they're giant. And then the proper definition is very interesting, because when we talk about the definitions, we talk about the history of paraclinoid management. The first definition was made by Drake, 1968, subdural cranioidectomy, London, Ontario, North America. And when we talk about the rest of the aneurysm, posterior wall, carotid cave, superior epiphyseal, we talk about Japanese, more extradural cranioidectomy, Dolenz, combined cranioidectomy, extradural and subdural, and release of the rings. And then it's very interesting to know about the history. The definitions are very important. And then when we see the history, and Jack knows that I am a fan of Hakuba. In 1982, he published the pure extradural cranioidectomy, because he was first a tumor surgeon, a skull-based surgeon. And then a skull-based surgeon always tried to take out a tumor, decompress the optic nerve. And that's the philosophy of the extradural cranioidectomy, shared by Dolenz. By Dolenz, vascular, and then Dolenz open the Sylvan fissure, expose the subdural space, and take out the clinoid with a combined technique. Drake, subdural, vascular surgeon, subdural. Split the Sylvan fissure, take out the clinoid, subdural, drilling. But in the Drake technique, the decompression of the optic nerve is not the goal of the surgery. But in the Dolenz technique, in the Hakuba technique, the goal of the surgery is decompress the optic nerve. That's the point. And then this is our experience. We have a little bit more than 400 aneurysms. And if you think about this, 60% of the cases, you only need to take out the clinoid. You can take for subdural. You don't need to take all the clinoid if you only want to clip. Because for me, the goal of the surgery is decompress the optic nerve. Then I do the extradural one. But you can do subdural, 60% of the cases. But in 40%, you need to release completely the rings of the carotid artery. And you can do for subdural route, I did, of course, but for me, it's very safe and very straightforward to do for extradural route. You can release completely the carotid artery, and you don't need to open too much. But the problem are the morbidity. The morbidity in our series in optic nerve is 8%. But let me talk about a little bit about the optic nerve, because my brother is an ophthalmologist, and he's expert in glaucoma, and he teach me a lot about the optic nerve. And then for me, I always remember my patient that I have one patient that lost both optic nerves, is blind. 0.3% is nothing maybe, but for me, it's the patient that always think every time I treat a patient. And the second morbidity is mainly is the perforators. Why? Because if you're going to do a temporary clip more than 5 minutes, you'll be in trouble if you don't have good collateral circulation. Now everybody talk about the collateral circulation because of ischemia, but 10 years ago, 15 years ago, the neurosurgeons doesn't know a lot like the neurologists today, and the results are good. Why my results or my group, the results are good? Because we are expert in this. Nobody can have no experience can operate this kind of cases in my hospital. But always, the patient have, in 8% of the cases, the clinical presentation is visual compromise. But if you send all the patients to the neuro-ophthalmologist, 20% of the patients have compromise of the optic nerve. That means what? one of each 2 patients only can realize they have problem in the optic nerve. That's very important. And the microsurgical damage is 8%. Giuseppe showed that surgery is 11 maybe in the series. We are lucky to have less on that compromise. But here I show you this slide because we need to work together with endovascular. When you have an unraptured paraclinoid, the problem is the optic nerve. When you have a raptor aneurysm, the problem is the subarachnoid hemorrhage. Look at the mortality in subarachnoid hemorrhage in paraclinoid. The paraclinoid, when raptured, are terrible aneurysms. When they're giant or large, the mortality is very high. You need to treat the patient because if you don't treat, the patient is going to die. That's the lesson that we learned 15 years ago because in that time we wait. No. You need to wait. These cases are very complicated and we will see later what we do, rebleeding and a problem. Now we treat with endovascular team and we put a coil if it's needed or we can operate as well. We operate in acute phase paraclinoid aneurysms. And in this case, for example, this patient came to me with this superior hypophyseal aneurysm and everybody what do? Show the surgery, the video, and after that you show the angiography, everybody happy. No. I want to show you the visual field of the patient. The preoperative one is in the up, 0.6 in the left side, in the left eye, 0.1 in the right. If you have less than 0.3, you cannot read. If you cannot read, that eye is not good. And then if you publish a paper and you put, for example, after the treatment that the patient have 0.7 in the left eye and 0.2 in the right, you see, oh, there's an improvement in the visual field of the patient, in the acuity of the patient. But it's not worth it because for reading, you need to go up 0.3. And in this case, we have 0.9 in the left and 0.7 in the right after the surgery. The field is the same, but the patient can read with both eyes. Why I'm telling you this? Because if you read that papers about the visual function after treatment, you need to read the results properly because sometimes the results are not good. In unraptured, you need to preserve the optic nerve. Now we're going to talk about technique. You need proximal control like any aneurysm. And what is about the surgery of paraclinoid? The surgery of paraclinoid is take out the clinoid. We made the same technique since 1999 to 2014. The classic one, the Dolenz technique, we name, and in 84% we take the clinoid. In 16, you don't need it. You can clip without take the clinoid. Very straightforward surgery. Contralateral approach or a little bit distal paraclinoid that you can clip it. And then why we take out the clinoid? This is for the residents. Because you need to have the whole picture. If you don't take the clinoid, you don't have the whole picture. You need to have the whole picture like you see in the angiography of the patient. You need to expose the clinoid segment and you need to decompress the optic nerve. That's why we made the technique. And we need the technology, the tools. The AC green is very good. I only show this in order to see in this patient with bilateral paraclinoid, we preserve the superior hypophyseal artery, the irrigation of the both optic nerves, and in this case, I'm very confident that the patient have no deficit. It's very important to make the flow. Everybody talk about bypass surgery, show bypass to show he is a big surgeon, but today, here is not about what operate Dr. Mura. Here is about if the microsurgery is good and is better for paraclinoid. And then it's not the surgery that I do, the surgery that a lot of people can do. A very, very well neurosurgeon with good preparation can do. And for example, only 6.8% of paraclinoid we made bypasses, like this case, and 16% of all my bypasses are done in paraclinoid. And then why? What I'm telling you? I'm telling you that you need to be a master in clipping for paraclinoid, not a master in bypass surgery, because the morbidity of the bypass surgery is higher than clipping. And the tools are important, not only for endovascular. The microsurgery evolved, new clips, new appliers. We developed these appliers with the Mizuho. The clips, for example, these low profile Peter Lassie clips. Peter Lassie now came with a new clip, the D clip. In my point of view, it's the best clip ever. It's a very low profile, very strong clip, And they modified the design, and now you can take outside, inside, like any clip. The L clip that they made before, that the problem of taking out the clip was very hard. Now this clip is the best. This clip came out 1 month ago. It's very, very new. And then you need to learn about the other specialties. For example, endoscopy, the suction irrigation concept. You see, the suction irrigation, got a good scissor. In my case, you know that I use Takayama scissors. For me, are the best scissors. And then what I want to show you today, you know, you can do the classic Dolan approach or Hakuba approach. We made this for 15 years, but you can change, you can improve. You can offer to the patients an improvement in your surgery, a less invasive surgery. That we are doing now for 5 years. What we do, we talk a lot about what we do. This is one of the papers with my fellows, Dr. Martinez Perez, now is in the United States. We studied anatomy. We came with the concept that the keyhole, the people think about keyhole with a minimalist surgery. But we want to develop a concept of key exposure. You need to take out of the surgery everything that is not worth it, and you do your surgery just the less invasive possible. Why? Because the endovascular offer not to open the head in order to treat the aneurysm. And the people, you talk to them, the optic nerve, you talk to them about the subarachnoid hemorrhage, but the patient think that just open the head is a huge invasion, but the results are important. We start to publish this. We start to, to demonstrate, we try to demonstrate this. And this is a video that we published in the ACTA the last year. This is a very classic paraclinoid, a lateral one. The lateral paraclinoid is a little bit difficult because when you take out the clinoid, you have the risk of rupture aneurysm. This is a mini-pterional approach described in 2007, but this is a little bit different because we use the mini-pterional approach, but now we use just the Hakuba concept, extradural route. And then I'm 18 minutes now, and then I'm going to fast forward. We made a mini peeling. We take the anterior clinoid with rongers. We seldom use a drill because I think that the optic nerve damage in surgery is because of drilling, the hitting. For me, it's very hard. You can take completely the clinoid. We are taking out here the clinoid. For the extradural route, we take 600 clinoids now in tumors and aneurysm. I have only 2 raptors, both in aneurysms. That aneurysm were aneurysms that have clinoidal segment aneurysm, transitional, in part intracavernous, in part subdural. The both cases did well because we can deal, because it was extradural. And you see here, we just open the point when you need. We open the dura, we release the optic nerve, we open the sylvian fissure a little bit, you expose the distal dural ring, you use the fibrin glue to deal with the cavernous sinus, and after that, we release the carotid, and this is the distal dural ring, the carotid artery, and the sac, and you see just a curved clip, very, very easy clip, not a terrible clipping. And the opening is good enough for follow all the principles of the good vascular surgery. I always put 2 or 3 clips because I want the patient have completely normal the carotid artery, and the closure is very easy. And after that, you can see here the post-operative CT angio. The patient did well. This is the craniotomy. This is not a keyhole surgery. This is a key exposure surgery. And the people said to me, no, this is only for small cases. You cannot clip a big aneurysm using this approach because it's dangerous. This is a bigger paraclinoid posterior wall aneurysm, the same surgery. The only thing I want to show you that you don't need to see the brain when you have an arterial pathology. When you have a glioma, when you have an AVM, you need to expose everything. When you have an aneurysm, you need to expose distal control, proximal control, decompress the optic nerve, and expose properly the pathology. You don't need to expose the brain. You can put a retractor, no problem. Here we have the distal carotid, the proximal carotid, but the key is the same that the key for endovascular, the instrumentation. I use a special clip. Here is the PCOM, then the aneurysm is proximal to the PCOM, then it's a paraclinoid. we separate from the cavernous sinus, but the key in this surgery is not the technique, it's the clip. You need to use a giant clip because a regular clip is not good enough for this aneurysm. And now I take in 20 minutes and then I'm going to show you the clip was okay. And here we decompress, the patient have a third nerve and the third nerve was recovery. And here, a small remnant in the aneurysm, medial. I made a CT angio for 5 years and this disappeared. The carotid artery, make a remodeling of the carotid artery, and now we have no remnant because the clipping take out most of the lesion. And why is it important to do this kind of technique? Because teaching, you can teach this. This case, the clinoidectomy was made for my fellow, and then you can see that it's reproducible, the technique, and it's competitive with endovascular. We need to be competitive with them. We cannot do the same forever with the patients. And this paper was brought by Ivan with his series, and this was published just now about the technique. We operate a lot of cases with this, of meningiomas, schwannomas, and the paraclinoid aneurysm. And even you can treat this kind of cases, huge one. And then this is about what? About decompress the optic nerve, about expose what you need to expose, and offer to the patient a good recovery. You see, you can put a flow diverter, I know, in this case, but for me, the problem is the optic nerve. And this case is not intracavernous. This case, the 80 or 90% of the aneurysm is subdural. And then we don't have time to see this, but the technique is the same. And I only want to show you that you can split properly the sylvian fissure. You can decompress the optic nerve. You see the ophthalmic artery. You see the carotid proximal, distal. You have everything you need. Why are you going to do the same surgery that you orbitozygomatic, transzygomatic? I don't know. I respect that because I did it for 15 years. But we need to make improvement in order to have better results in the patient. It's all about the results. And here you see, a lot of people said to me, you need to do a bypass in this case. But in this case, I want to prove that the clipping is still worth it because it's safer. The patient have a good decompression of the optic nerve. You see, I can clip completely the aneurysm and it's okay. And then the technology again is very important. We modify the clips, the 747 clip, lateral one of Escula or Peter Lasky, it made a longer one, designed for this kind of aneurysms. Why I did this? I learned this from endovascular. They always develop tools. We, the neurosurgeon, must develop tools as well. Why not? Why not? Subarachnoid hemorrhage, a superior one. Now I only left 2 minutes. And then what I want to show you, if you do this kind of surgery, what you must avoid in Raptor paraclinoid, mobilize the frontal lobe. When you do extradural surgery, you don't need to move the frontal lobe because you work just using the temporal corridor. You can decompress the optic nerve, you use the temporal corridor here, and you take out the clinoid, you decompress the optic nerve, and look at this. I want to show you something. The retractor I put in the temporal side. I never move the frontal. And here is the optic nerve, the carotid artery, proximal neck, distal neck, everything is safe. And now we clip with a modified 747 clip. You see, the tools are very important, not only the technique. And the brain very relaxed after the surgery because we're opening the iliac membrane, the lamina terminalis, etc. We can go farther even. We can do keyhole surgery, true keyhole surgery in these cases. We described this a little years ago. Finally, was published in 2019. Again, the instrumentation is very important. I'm finished with this. And we are operating now 14 cases with just keyhole surgery in very selected small aneurysms. Why I did this? Because the endovascular offered to these people flow diversion. And the flow diversion got the problem of the double antiaggregation. If you do this surgery, the patient is discharged in the same day or the next day after the surgery with very good results. This is nothing new. 1982, I copy everything from Jakuba, Dolens, etc. And I cannot show you this case, but we have this published as well in February of this year in the Acta Neurochirurgica. This case, you can see the video in the online. And I want to finish this. Here, I'm not going to read what I brought. I'm going to say to you, microsurgery evolves every day. We are not doing the same surgery than 30 years ago. I am not doing the same surgery that I did 5 years ago. I changed because I'm now involved with development of tools, scissors, appliers, clips, everything, suction irrigation. We must be involved as a surgeon. We need to offer to the patients less invasive techniques. But for example, this case, 2 months ago, I operated for pterional. It's impossible to operate this aneurysm for mini pterional because you need to clip using the subfrontal route. But I clip it, no bypass, no nothing. Clip. Thursday, the patient discharged the next Tuesday. This is true. The surgery is still valid for paraclinoid. In my point of view, is much better because I am a neurosurgeon and operate, of course. And I want to finish with this. We need to work as a team. Not like 1997, my professor Loaiza with Dr. Badilla. This is Dr. Rivera, neurosurgeon who do endovascular in my hospital, and me discussing a case in the angiography to deal with the case and said, okay, which one is the best treatment? In this case, I convinced him to operate, but we need to work together. Nobody have the answer alone. Thank you to my fellows, and thank you for your patience.
Thank you, Jorge. Very nice. Very nice. Thank you. We're, of course, saving the questions till the end. And it's now I'm going to move on straight to our panelists. And I'll start with Aaron. Oh, that's your presentation, Aaron, correct? Please go ahead. Are you muted? You're muted, Aaron.
Here we go. Sorry about that. I was saying that that image shows a lot of minimally invasive techniques right there. So hold on one second when I try to share that. Well, I wanted to take a moment and really thank Jacques. I know Jacques for many years, and he has proven himself not only as an incredible leader, preparing the most incredible educational symposiums, both online and virtually. As a member of the Dublin Board of Directors, I've had a chance to work with him, and he's a superb surgeon, an amazing leader, and a dear friend. And Jacques, I want to tell you how much we have respect for what you do and how much you have contributed to your neurosurgery with your huge legacy. So before I start, I want to definitely give credit when it's due. I really enjoyed watching, both Jorge and Giuseppe discussing. Before I start and describe my case, as you know, Neurosurgical Atlas has been a tremendous source of fun for my team and myself. This is an image, probably one of the most intriguing images that our illustrators have done. I'm somebody who loves art, and neurosurgical illustration is something I've always enjoyed. And you can really enjoy the intricacy of this image and the perspective that's been created. And I can imagine how much work it would take an illustrator to understand the anatomy deep within this area. I wanted to also share some of my personal biases. Obviously, just like Jorge, I'm somebody who loves neurosurgery and operating and doing microsurgery as much as Giuseppe does and all of us do. But I have to say that you have to provide the patient with an opinion that you would provide your own family member. And flow diversion has just revolutionized paraclinoid aneurysm surgery. There's just no question about it. Of course, there are very rare cases where there's significant visual compromise and you really want to be able to decompress the nerve very quickly. But I would say 90 to 95% of the aneurysms are very well suited, very well effectively treated with flow diversion, very durable, and nobody can question that kind of result microsurgically. You know, we can all try and work hard and do well in terms of microsurgical techniques, but again, you have to give credit when it's due, that flow diversion has just moved a lot faster than microsurgery forward, and therefore it has really surpassed the advancements in microneurosurgery to provide better care for our patients. So if I have to say today, what is really the first option of treatment for my patients in the clinic? It is flow diversion. 95% of my patients who have a paraclinoid aneurysm undergo flow diversion. It's just the right thing to do. It's something I would choose for my family member, and therefore that's what I'm going to choose for my patient. No matter if I'm endovascular or microsurgery or both, microsurgeon or both. Again, it's just the right thing to do for our patients. So with that in mind, I want to show a case, a video of a surgery, and please, Jacques, let me know when I'm a minute left. I probably will go over. It's a patient who presented with, you know, visual decline, and we went ahead and did this. You can see that the neck is very much covered by the anterior clinoid process at the tip of my arrow. And we went ahead and did an extradural clinoidectomy in this case, again, because vision was an issue. This is a relatively actually narrow neck, and one would say that it's very good fit for flow diversion. But this is really a case from the time where, you know, flow diversion was still establishing itself as an effective modality, but still was offered. But because of the visual decline, we went ahead and did this through a pterional craniotomy. I'm not going to emphasize how the head frame is, skull clamp is placed. The standard pterional craniotomy is obvious. A little bit bigger or smaller, I don't think that makes a big difference. The meningoorbital band is cut a little bit. The anterior craniotomy is performed extradurally. I just think it's a much better procedure if it's done extradurally, because it prevents all that, you know, extra dust and bone dust that is created if you do it intradurally. Obviously, you have to be very careful that the aneurysm is not attached in its mid-body or dome to the anterior clinoid process, dura. The technique of drilling is very standard. I think all our viewers knew very well how to do this. And here you can see further drilling is performed. The optic nerve is first decompressed, as you can see here. So when you manipulate the anterior clinoid process, you're not placing the optic nerve at risk. I'm going to go ahead and go a little bit faster forward. Here you can see the anterior clinoid process is being delivered like a tooth, just being pulled out of the socket of the jaw. And it's really a fun technique. It's quick. Unfortunately, it's becoming a lost art. You can see the optic nerve here. You can see the anterior clinoid process that's been removed. Usually I don't use retractor. I open the dura just like Jorge mentioned, wherever you need it. Really a small opening. And then when you get in there, it's truly beautiful. I mean, the anatomy is gorgeous. The clipping is beautiful. It's just pristine and it's enjoyable. In an unruptured aneurysm, this is as good as you can get when you really want to enjoy the anatomy of the anterior canal fossa. So here we went ahead and we used the retrograde decompression technique. We threw the balloon in the neck and put a distal clip to the aneurysm as the balloon is going up, and then retrograde suction that our endovascular colleagues do. You can see the neck of the aneurysm, compression of the optic nerve. You can open the dura there to be able to see more of the neck of the aneurysm. And then you really can do an angled clip. This one really entered into the cavernous sinus partially, so it's potentially a carotid cave aneurysm. So we went ahead and opened the distal ring as we had a clip on the aneurysm just to decrease the volume and the girth to provide me with more space. And after that sort of a tentative clip technique, we went ahead and more proximally were able to see the neck and place 2 clips in a tandem fashion. You can see the distal carotid there, and it's filling nicely, and the patient did very well. But then put a piece of muscle to just fill in the area of the anterior clinoid process. So the message is really the fact that paraclinoid aneurysm surgery is an incredible art. It's beautiful. It's fun for microneurosurgeons. However, I think endovascular therapy and neurosurgery has provided a very much superior technique that has proven itself not only to be safer, but also to be very durable. And I have to congratulate my endovascular neurosurgery colleagues, such as Giuseppe, who truly has done tremendous work with the folks in his group. At the end of the day, it's what's right for the patient. And we're proud to see aneurysm surgery progress in the hands of our neurosurgery colleagues.
Thanks, Aaron. Jorge, would you like to rebut Aaron's statement that your presentation was nice, but essentially not for the future of the neurosurgery?
Really?
That's what he said.
No, what I can say about the future of neurosurgery is what I said about teaching. If the young people are interested in microsurgery, it's because we have a future. If, for example, endovascular is the only answer, nobody wants to operate. And every day what I see is the young people want to operate. If you give the proper message, the people believe. You see, I think that endovascular is faster, is more glamorous. I don't know if the word is correct. And but the microsurgery for me is something that it have always a future. I'll tell you, I'm listening about the end of microsurgery since I started in 2002 for 18 years. But still we are here. That's the proper answer.
Giuseppe, if you could unmute yourself for a second. Maybe I see some of the Q&As. We'll get to the Q&As later, but maybe it's the right time to ask the question. Who do you think is a good microsurgical candidate for a paraclinoid aneurysm? Who would you recommend? For whom would you not recommend endovascular treatment and microsurgery instead?
Well, I think that the patients where microsurgery is still an option and should be considered are, as I said, those very large and giant symptomatic aneurysms. I think that if we really look at the overall numbers, the risk of complications and primarily delayed aneurysm rupture, it's not insignificant. And then in those cases, of course, you have to wait what are the risks of microsurgery. And that's the type of aneurysm that I would have a lot of anxiety to treat, those truly giant and symptomatic paraclinoid aneurysm, especially non-cavernous sinus, where you do take a chance when you use flow diverter, even in the current era.
But do you agree?
Then,
oh, sorry, go ahead.
Yeah. No, then there are specific situations. For reasons of time, I did not show one of the patients that I treated surgery was a lady that had already contralateral visual loss, was losing vision on the ipsilateral side. There was a 11 millimeter carotid ophthalmic artery aneurysm. I think microsurgery is a much more controlled way to decompress the optic apparatus in a case like that. So, as I said before, it's nice to have options, and there is no question that even with flow diversion, when you go into the true giant and symptomatic aneurysms, then it becomes problematic too.
I was going to say, particularly in the first instance you described, particularly if they have pre-aneurysmal carotid stenosis. Do you remember that in the early days which showed paradoxical rise in intra-aneurysmal pressure after deploying a flow diverter, which was almost counterintuitive, but I remember those early papers showing, delayed hemorrhage. Then what do you do with the problem of, if microsurgery will be reserved for the complex cases, we certainly won't have enough microsurgeons who will be comfortable just clipping giant cases if they don't know how to even clip a small case, because they're all going to endovascular. But I'll leave this for the conversation later. Anybody wants to discuss with Aaron his presentation? Anybody has questions for Aaron before I ask Amir? Hello, Amir, to maybe upload his case.
Hello.
Jorge, you have something?
No, I'm saying hello to Amir.
Thanks, Aaron. Well, Amir, let's see what you've got.
Do you see my screen?
We do.
Okay. And you hear me well as well?
Yes.
Well, yes, your voice in all its shortcomings, we can hear it, yes.
Jacques, thank you very much for including me in this webinar. First of all, you know that besides being a great friend of mine, you are my mentor. I never really work with you, but you know that your opinion matters so much to me that whenever I'm in the dire straits and I want the last resort, I will come to you and say, hey, Jacques, what do I need to do here? So thank you very much for so many years of friendship and a great collaboration we have had together since I was a senior resident, chief resident fellow, and now obviously many years in practice. And also I have to congratulate you for this fantastic webinars. I think you are the only person in the world who can keep doing this. And doing one webinar or two is something, but keeping this with such a fantastic panel and audience for like every week, this is really something that only you can do, and everyone knows that. So and I wanted to thank Giuseppe and Jorge for their presentation. I think I totally agree with the overall concept that Giuseppe presented. I wish he would have talked a little bit more about I know that PUFs have the results for ophthalmic symptoms and optic neuropathy, and I know that the results are in favor of flow diverters, but I have to some extent my personal reservation on that. And with regards to Jorge, I think one thing that I wanted to mention, is that having a follow-up with CTA for this paraclinoid aneurysm, when specifically there is so many clips, I'm wondering if that's really gives you the right answer about that small residual or what happened to that residual. So this is just a simple comment, but both presentations were very good and obviously biased on each side, which is what this webinar is meant to do. And now, personally, I have to say, I do believe in ophthalmic aneurysm surgery, and I do continue to operate on them in a few a year. Obviously, in our institution, vast majority are treated endovascularly, but we do a few a year. And actually, one of my residents is looking into my series over the past 10 years. So we have a decent number, and hopefully we come up with overall results in terms of neurological deficit, in terms of optic nerve problems, total occlusion rate, and anything, including mortality. And one thing I can tell you, and I have the utmost respect for endovascular treatment. I am doing myself now an endovascular training, and hopefully within a couple of years, I will be able to do myself the flow diverter on my own. And the results are fantastic. One thing I can tell you is that we look into our own series. If you just look at the extreme complications in the series of open vascular surgery for aneurysm, there is no major neurological deficit or no death. And we will have the results and we will see. On the series of endovascularly treated ophthalmic aneurysm, unfortunately, despite excellent result in vast majority, we have mortalities. So this is also something that we have to consider into the decision making. But again, no doubt that the first treatment for vast majority is flow diverter, specifically for more complex paraclinoid aneurysm. But I would say absolutely the best treatment. I would not go that far. I would say still there is room for a percentage of paraclinoid or aneurysm to undergo open surgery. And that's our practice, and that's what I do. not frequently, but you know, in an infrequent fashion. And I think that's where the field stands at this point. I don't think it's 100% answer, but it's definitely the balance is in favor of the endovascular. And I wanted to show a case that is more regular. That's a real life of seeing a patient, a young patient coming with a large ophthalmic artery aneurysm, like a 29-year-old woman. And I really wanted to challenge the panelists and our speakers to see what would be the best option for her. But Jack sort of pushed me to go for a more complex case. So let's look at this case. This is not a routine neurosurgery case, but still something that, you know, major centers like all of you and us will deal with once in a while. And this is a 42-year-old woman who presented in 2012 with subarachnoid hemorrhage, and ophthalmic artery aneurysm was diagnosed and coiled. She had recurrence in 2014, underwent, I don't know all the detail because all these procedures were done in another institution. This is something that I gathered from my operative report and my recollection. Underwent further treatment, but mainly with neuroform stent placement. So she did not have rebleed. She had only recurrence of the aneurysm. I guess she was followed up. And then this aneurysm further grew and had further recurrence. The part was partially thrombosed and underwent one or questionably two flow diverter in 2017. Few months later, she presents with seizure, and upon neurological exam, she's found to have a right optic neuropathy and bitemporal hemianopia. Vision on the right side is weak, 2200. On the left is normal. And she has a partial field cut, obviously is bitemporal hemianopia. And just interesting to know, her mother had a subarachnoid hemorrhage and she fully recovered from it. She's married, has 2 kids, worked for a drug company, and she's a smoker, but not a heavy smoker, but she still smokes, mild hypertension, on dual antiplatelet treatment. So these are the pictures when she presented with this recurrent aneurysm, partially thrombosed. And the reason I picked a picture that shows this edema in below the optic nerve. You can see the edema around the aneurysm. So this is a partially coiled now, partially thrombosed, recurrent aneurysm with a couple of stents in the carotid artery, age 42, and visual compromise, as I mentioned. And this is what we see. And she had seizures, so that I guess this picture was taken when she had seizure leads the angiography. And you can see the recurrent part of the aneurysm, the coiled part of the aneurysm, and the thrombosed part that we did.
Amir, can you use your pointer for the audience?
Pointer, but the pointer
doesn't show.
For some reason, it doesn't show on the video, unfortunately.
Okay.
It's on your picture, but no, I was trying to do that, but
yeah, no problem. And before you tell them what you did, just obviously ask their how would they handle it.
I want to go, and if you have time, we can just quickly ask the speakers and panelists what would they think. So this patient with this multiple recurrence of ophthalmic aneurysm, young patient, and you can see you can see on this sort of 3D picture the open part of the aneurysm, the coiled part, which is more medial, and the thrombosed part that is not visible here is superior. And you can see the neck there is no real neck. It's a very, and I believe actually that they only put one flow diverter because they had difficulty access, but somehow in my operative report, I had mentioned that she underwent 2 flow diverter placements. So, and this patient—
Amir, sorry to interrupt you. Can you, I don't know if you can show us where you think the flow diverter begin and end, or you cannot tell on this image?
No, I can tell because I have the subtracted imaging. It's a very good coverage of the neck, but you know, there are a lot of metals there because there was 1 neuroform stent before and 1 or 2 additional stent. It covers from the PCOM to the cavernous segment. It's not a coverage issue.
Okay.
But obviously, I cannot comment on the detail of the procedure when it was done. So now this patient, I would like to ask, maybe, do we have time to go through the panelists, Jack? Or
well, you know, that's the idea. Yeah. I want you to, you run the show. You ask whatever you want to ask.
I'd like to ask first Giuseppe and then Babu and Robert. Very briefly, would you consider any further endovascular treatment?
Well, it looks like she has already had most of the reconstructive endovascular treatment. In this case, what I would consider a balloon test occlusion, and then parent artery sacrifice with or without with or without bypass. I think the main issue is, number one, to remove the pulsation, and sometimes that alone can result in a decrease of the mass effect. And then, of course, take care of the aneurysm.
Babu?
Yeah, I agree. I mean, it's a tough one, especially with not knowing exactly where the pipelines are in terms of a direct clipping or a direct approach. But I would probably think about a balloon test occlusion and potentially clipping it or trapping and bypass.
And Babu, do you agree, or you have other suggestions?
I agree. You notice why there will only be one Babu and one Bobby in two separate practices, right? So, there's yeah, I think we have to. You've used all the endovascular options, you know, besides the endovascular sacrifice, right? So, yeah.
But you don't think adding more stent, like if it was only one flow diverter, adding a second or third flow diverter will fix it?
No, I think anybody in here who's used one or two realizes after two you need to be thinking about other things. That's kind of my approach. I've had plenty sent here that are similar, but in fairness, you know, you made me think about a very similar case where the first approach was surgical, a great surgical result, and I've now placed two flow diverters behind it. So,
Amir,
it's bad segment, right? So we got to figure out how to treat the bad segment.
Amir, I think in this patient, one of the issues is the fact that there is a pre-existing stent that might have precluded adequate position of the flow diverter, and that's one of the reasons why probably the flow diverter is not working too.
Although it seems that it covers very well from the PCOM all the way to the almost pre-cavernous segment, but yeah, you know, there is a construct before, so.
I know this is your segment, Amir. The surgical management of a flow diverter, I've heard some interesting editorializing on it. You know, I've clipped neuroforms and they come back in terms of management. And Rocco, Armand, and Randy Bell produced a very good paper in the lab that looked at what happens when you put a clip on a pipeline. They don't do very well, just like the old stainless steel stents. I heard a very well-renowned neurosurgeon recently tell me that he has placed multiple clips on multiple pipelines and they do just fine. And
I heard him say the same thing, and I don't fully believe it.
Yeah, out of respect, I turn my video off. But
yes, I know who we're talking about. Yeah.
Okay. So is that are we not agreeing with that? I think that's like useful. I would hope that doesn't.
Well, I mean, that would be, you consider obviously temporary trap that segments, but technically, if you're just going for clipping of an aneurysm, we can technically do it without touching the pipeline. But obviously, for an aneurysm like this, that's impossible. So, yeah, I'm concerned of a kinking of a pipeline that does not reopen. Sure. And I have done that on Neuroform, but I can't remember if I have put a clip on a pipeline in a temporary fashion. Permanent, yes, not temporary.
Okay.
Aaron, do you, in your institution, this patient would go to surgery?
Yes, absolutely, Amir. I agree with the plan.
And Jorge, I'm sure in your institution, this patient will get further stents, right?
I think we discussed, and it's important to know how is the optic nerve bilateral to see, for example, we do OCT, you know, to see the retina, and I see how is the accuracy, how is the visual field of the patient with the three data. If the patient had a compromise in the left side, in this case, we go for surgery, because it's the only way to improve the contralateral side is surgery for the decompression. I think that coils you need to take out in the surgery. But for me, this case is for a BTO. I agree completely. After that, second generation bypass or all name high flow, and after that, temporary trapping. Take out the coils, everything, and I try to clip it, preserving the stent.
So considering that there is a pipeline there that might not do well with your temporary clipping, you would.
No. The temporary clipping is not in the flow diverter. It's in the neck. The ophthalmic artery is distal to the pipeline.
Well, I mean, it's
With the VTO.
and you would include the choroidal artery, or
Yeah, you need to see that. But you can use, for example, intraoperative motor monitoring. Interpretive motor monitoring with the, and if you see that everything is okay, you can see in your surgery. But I completely agree the anterior choroidal is a problem. But I think you can cut the aneurysm very far from the neck, because you have the compactation of the aneurysms is very big. You have a lot of alive aneurysms or live aneurysm you can try to clip.
Amir John, this is Aaron. I think you have to be prepared for a radial artery bypass. You may open, just look around, and I think what Jorge is thinking, maybe consider inspecting intraoperatively, but you have to be absolutely ready after you inspected things to have the arm ready for a radial artery bypass, and have a low threshold to do that.
Sure.
Okay, Amir, tell us what you've done.
Test occlusion, and the patient, I would say, marginally passed it. So it was not passing it in a sense that I was confident to say, oh, we can just occlude the carotid. And also, she's a young woman. I did not want to necessarily, I did the mainly balloon test occlusion to have an idea of the collateral circulation more than for the aim of carotid occlusion. And again, I reemphasize the left eye is completely normal despite that edema that I showed, but the right eye is poor. OCT shows a lot of nerve loss. And I didn't feel that this is a good case for direct clipping, as specifically when you look at this neck and considering the stent in the carotid. And I just wanted to have one firm plan going in as opposed to go in with a plan A and B. And this is a replacement of the whole carotid artery. As some of you might know, I love internal maxillary artery, which is shown here. And we can get a very excellent vessel just behind the maxillary is the second segment of maxillary artery. And that vessel is perfect for anything. But I specifically show this picture just to, you can see how nice this second segment of the IMAX can be. But I have never done and never used the IMAX to replace the whole carotid. So for this one, I decided for a traditional bypass. So this is exposure to the right sylvian fissure. And this is a graft on the larger M2 trunk. So this is a segment that the occlusion is better tolerated than more proximal. And is a very large vein graft, as you can see. There is almost a mismatch, but we can deal with the mismatch and deal with the area if there is a dog ear. So run one side, and I believe I did interrupt it on the other side. So this time obviously is under occlusion, and the monitoring remains stable. That was probably about 25, half an hour of occlusion time. And we open the clip, we let the MCA flow until we do the proximal part. So for this bypasses, I prefer to do the distal part first, and then this is the graft flowing, and then put the clip just above the bypass, clean the graft, and go to the neck, take the ECA, and I put the graft under tension. This vein graft needs to be under tension, otherwise when you open them, it's gonna kink on its own. And you can see I'm almost pulling on it, and to have it under tension. And now we get it, let it flow. And now that the bypass is open, obviously the job is not done yet because we want to do the main aim of the surgery. And now I'm putting the clip on the pipeline, which is what at the level of the PCOM, open the aneurysm. And this, I think that's the reason this aneurysm was growing. Look, after full trapping, except for the ophthalmic artery, I'm getting the ophthalmic artery now, but you saw how much of the back bleed I had from the ophthalmic artery. And I'm wondering whether that was the cause for further growth of this aneurysm. And I did not take the coil out. I really felt that I would risk the left eye or left optic tract or optic nerve by putting those coil and edema around it. So please tell me if you think that was the right choice or not. But I did not feel comfortable going and pulling those coil with that edema around it. But I decompressed the thrombotic part of the aneurysm, and the part that was patent is gone. So almost more than half of the aneurysm is gone. And this is the picture we got. This is already a follow-up at 1 year. And you can see the difference, the IMAX, you can see on the AP picture at the neck, the IMAX, look at the difference between the two vessel size. So that's why I did not want to replace the carotid with that IMAX. I didn't think it was good enough. And this patient now, I guess 2 years to the follow-up, there is no improvement of right visual acuity despite what I did, but improvement of visual field. She had no further seizure, weaned off after 2 years per report. Her MRS is good. She's on aspirin, and I'm following her for another angio or any imaging in 5 years. But she's doing fine. She's back to her life, but the right visual acuity is still pretty poor. Thank you.
Thanks, Amir. Yeah, no, I agree with, of course, not moving the coils. There is no reason to. But the second thing, one thing you said earlier, actually the presence of a pipeline is helpful in clipping an aneurysm. It's an internal stenting that actually prevents it. Now, in this case, I don't know if it was doable or not, but you know, it's nice to have a stent that prevents the clip from stenosing the artery underneath. So, you know, you can use it to your advantage.
In terms of putting it, I was mentioning about putting a clip on a pipeline as a trapping of the carotid and then taking the clip off. And if the pipeline,
right.
That's what I meant.
Oh, I see. Okay, got it.
Because of the clipping of the neck, that's good. But I was just talking about trapping the segment.
Comments from any of the panelists about Amir's presentation?
I have a comment.
Go ahead.
It's very important that I want to stress what Amir just said and show in the slide that maybe we are not fighting for the right eye. We are fighting for the left eye of the patient. It's very important that in these cases with huge aneurysms, sometimes you cannot save the ipsilateral optic nerve, but you can save the contralateral. It's very important. I talked that with the patient. The effect in the contralateral side is sometimes impressive. You can have, for example, almost blind, half of the visual field lost, and you can recover completely. You see, and that's important to stress because we're talking about why the microsurgery sometimes is better than the endovascular.
Anybody else?
You know, Jacques, I'm just going to mention my 5.5-year-old daughter is watching this presentation with me and listened to all of you guys and then said, Daddy, Amir's accent is just like yours. So obviously Amir and I are from the same country, so.
Yes, indeed. Say hi. What's the name of your daughter?
Hera, can you see me okay? I guess not.
Yes, we can. Now we can. Hello.
Hi,
so her name is Serene. She's learning about aneurysm clipping at age 5.5.
Very good. Very welcome.
I'm not really listening, Daddy.
Oh.
Looks like you, Aaron.
Well, welcome. Stay with us unless you have something more fun to do. Bobby, may I invite you to load your slides? What happened there, Amir? Your thing is frozen, no?
No, I'm not sharing. Someone took my share off. Actually, I was trying to pause my share. I stopped share.
Yeah, perfect.
Yeah.
Bobby Stark, yeah.
Is that the right screen?
No, not this one. This is double slides.
Okay.
Go to display settings on the left there, as Ignacio said, I guess.
Is that the right one?
Yes, perfect.
Okay.
Great. Well, first of all, thanks so much, Dr. Marcos, as always, for putting together these incredible symposiums, and to the other panelists for some amazing talks and cases. My disclosures, my training, as Dr. Marcos said, endovascular, but also open vascular and skull base. You know, I think it's nice that at all these centers to have all the neurovascular tools at hand. You know, we have aneurysms that we can clip and coil. We have atherosclerotic disease that we can stent or we can do endarterectomy. We have fistulas that we can treat with surgery, with embolization, or with gamma knife. But I think it's really based on the patient and the disease characteristics. There's an optimal approach. So I tried to look through, you know, some of the more interesting cases and go through and try and pick a case that I thought really had a lot of pluses and minuses for both endovascular and open vascular, and potentially some controversial aspects for both. So this was a patient that presented to our institution in 2016. They were transferred from another hospital as a tumor. I didn't want to put too much of the patient's details, but she's an elderly patient presented with severe acute onset of headache, no past medical history of headaches. You can see here she has a history of hypertension, COPD, coronary artery disease, asthma, DVT, GERD, sleep apnea, prediabetes, and very minimal peripheral neuropathy. And she's neurologically intact except for really just a minimal alteration in distal sensation. You can see here, this was the initial CT scan that she had at another hospital. Here you can see on the coronal view, you can see this, target sign. This is her MRI, MRA. Again, you see the target sign here. You see some flow voids. So I think for many of the residents, you know, these cases look a little bit like this, but my mother always warned me about free candy. And you see here, looking sort of closely at the T1, there's actually a very small area here where you can see that the aneurysm is leaked. And, you know, she never had a history of headaches or any neurological problems before this. And her presentation was acute onset. She said, I had severe headache. And I think that was partially explained by a small amount of blood that was here. So I'll show you the angiogram that we did. And this was in 2016. This was a radial angiogram. And interestingly here, you can see this part of the aneurysm grossly out of proportion to what you're seeing on the MRI. You can see she's got numerous aneurysms. I'll show you some better images in the 3D, but you've got 1, 2, 3. There's a couple more aneurysms. Here you can see better. This one is a double-pronged sort of dysmorphic aneurysm. There's one here. There's one here. There's one down in here. I'll show you better on the 3D. So here you have the partially thrombosed aneurysm that we're primarily seeing on the MRI that's leaked. There's another one here at the sort of, you know, this bulge at the neck, or this aneurysm that's sort of off the neck of the aneurysm. There's this double-pronged, which is probably better seen on the true angiogram. This reconstruction is not great, but there's this sort of this double-pronged aneurysm that's just distal. There's this one that's in the cavernous sinus, and then she has this small MCA aneurysm. And then on top of that, a couple other key things is that the ophthalmic artery is a variant. You can see here it comes off the cavernous segment. I don't know if you can see my pointer, but that's important.
Yeah, we see it.
And then additionally, this is the anterocoroidal artery, so it's just distal to this double-pronged aneurysm. You can see there's no real PCOM to speak of, and there's no real ACOM. So she doesn't have significant collaterals. So treatment options, you know, maybe in Miami it looks a little more like this. These are our traditional patients, but these are all the options: coiling, ICU sacrifice after balloon test occlusion, balloon-assisted coiling, stent-assisted coiling, flow diversion with coils, microsurgical clipping with suction and decompression, trapping with bypass, wrapping. And then on top of that, you have to keep in the back of your mind, you know, does she need a shunt, or will she need a shunt, and how does that sort of impact your decision making? So I don't know if we want to start with the panelists and go around and say, you know, what you would think you would do for this lady.
Giuseppe, is this a clear-cut indication for flow diversion for you with all these multiple aneurysms, the disease?
Well, here I think this is a case that well illustrates what I was mentioning before. It's how you really have to analyze. You know, we tend to focus on the technical aspects, but here I think what we have to analyze: number one, it's an elderly patient. Number two, she has a lot of comorbidities. Number three, she has a giant partially calcified aneurysm. So these are all factors that would put her at high risk for surgery. From a clinical point of view, she probably presented with an acute event, maybe a small leak from the aneurysm. I agree, important, it's what Bobby mentioned, if you need to be ready. She might develop hydrocephalus if you do something to close the aneurysm. She might have relative swelling. So these patients, what I would do, and then the other thing, analyze carefully on the T2, it looks like the clot is mostly I.10. So that suggests that most of the clot is fairly organized and long-standing, along with the calcification tells us the aneurysm has been there for a long time. So to cut short, what I would do, I would I would coil the filling portion of the carotid ophthalmic artery aneurysm, forget about all the other bumps, then let the patient stabilize, see what happens, and then at the later time, consider a flow diversion if she has a recurrence at the neck.
You're doing this because you want to avoid double antiplatelets?
Correct. I want to avoid double antiplatelets and to put a flow diverter in what is an acute situation adds additional complexity to a clinical picture that is already fairly complex. To secure that aneurysm and prevent further rupture just by packing coils in the residual dome, staying away from the neck. It's a fairly safe and straightforward procedure. Not ideal, but I think it will take care of the most important acute clinical issues, and then at the later time, in a semi-elective fashion, if needed, you can, a flow diverter will provide most likely complete occlusion.
Do you think, Giuseppe, coiling the angiographically visible portion protects a giant partially thrombosed aneurysm from rebleeding, since they mostly rebleed, very distally into the dome?
I think it provides, if you look at the MRI, looks like on T1, you can almost always suspect that there was a jet and there was a portion that a fresher clot. So I think, again, it's a different, every patient is different. You can see there, you can make almost like there was a portion that the clot is more acute at the top. And I think that buffering the jet by packing the residual filling portion of the aneurysm most likely will provide the short-term protection that you need. And then at the later time, see how the aneurysm evolve, make sure she doesn't need a shunt, and then go for a more definitive treatment. I think it will provide adequate protection. Of course, in our profession, nothing is 100%.
Jorge, how would you handle this tough problem? Are you muted? Did we lose Jorge? Okay, anybody else on the panel? Oh, sorry, Jorge, how would you handle it?
Yeah, I think for me the problem in this case is the calcification. The calcification. Can you show the calcification, please? Of the you have one of the slides with the calcification in the sac. The size for me is not very important, but the calcification, that's a problem. You see, you have a calcification in the neck, and then it's impossible to deal with that for clipping. It's very hard. The clips never close. You compromise the carotid artery, everything. If we need to talk with the patient, maybe in this case for me the problem is if the patient got enough good condition, I do a bypass and a trapping of the carotid, and I decompress that. You see. But I think for microsurgery, the calcification in the neck is extensive. And then it's a problem for clipping. There's no clip for that. You see?
But if your endovascular colleague, Jorge, back in Santiago tells you, I can place a flow diverter here, would you disagree with him?
The problem is they show that the patient have a bleeding in
right.
the aneurysm. That's a problem. But you need to put in the balance the medical condition, the how's the patient, talk with them and everything. But in this case, you see the ophthalmic artery is a dorsal variation intracavernous, and then you can put a clip. You take out the clinoid and put a clip in the clinoidal segment without any compromise of the optic nerve, and just distal to the small aneurysm proximal to the choroidal with a bypass. I think it's safe.
Babu, you are in Dallas, where the Dallas maneuver was invented by Duke Sampson and Hunt Bajer. Does it have? It's been more than 30 years, I think. Does it have any? It is, isn't it? Yeah. Does it play any role in thrombotic aneurysms? Have they? I don't remember the numbers in their original series, but
I think Jorge's point about the calcification really takes away how much manipulation you're going to do with the wall. I think I agree with Giuseppe. I think one of the things that we all see in the endovascular world is the kind of reflex almost to put patients on dual antiplatelets when we do our or some sort of antiplatelet when we do our endovascular procedures, and then 6 weeks later we wonder why all the coils are sitting up in the top as the clot was remodeled, especially in a ruptured aneurysm that has a channel. So placing coils in an aneurysm which has a decent neck, allowing that to kind of provide some scarring, continue, and then kind of go from there with the recurrence. There's as Jorge mentioned, the ophthalmic is not there, the PCOM is well distal, so there's not a whole lot to keep it open except for the fact that it wants to grow. One point, I guess, the shunting part, if you make this somewhat analogous to some of the larger basilars, we see all the time that you shunt them because you think that's all they need, and then you wonder why they rupture. I think in a ruptured case, it'd be best to have it as secured as you can make it before a shunt's placed, make or need a shunt, because I think that does change the dynamics of the aneurysm wall, calcified or not. The calcification is annoying at the surgical site, and debulking an aneurysm like that, I think we mentioned that before. I think we do more hurt than harm. It's already gently moved the brain out of the way, and we're going to tear it out. So I think I would avoid that.
Giuseppe, one of the audience member, Dr. Abdallah Zaidan, is asking you, how about the mass effect? Does placement of your coils, is it dealing with solving the mass effect?
Well, I think the placement of the coils is it again. To me, I think most of the thrombus is organized because you can see on T2. And I've had cases where just packing the residual portion in similar situations, you remove the pulsation, and the patient presented with acute headache. In this case, I don't remember, but there was no compromise of the optic apparatus, or at least clinically significant. So, and I think it would deal with the acute problem, and then at the later time, you can, but often, and it's an old concept, Drake mentioned about it, some of these giant aneurysms, you remove the pulsation, and if you have symptoms related to mass effect, then they might go away.
Bobby, you take it back.
Yeah, I mean, great thoughts by all the panelists, and those were a lot of things that we discussed and were going through my mind. I mean, I was particularly worried about the calcification in a younger person, maybe more inclined to trap and bypass. Also, pretty worried about putting in a shunt up front because I think it may decompress the system, and there's already been bleeding, and that might lead to instability. So in the end, we pretty much went with the approaches kind of discussed by the panelists. So, this is probably a 30-minute coiling case. So, we discussed all these things. So this was a radial approach. And you can see here, there's a good neck on this aneurysm. This is a very easy coiling, probably about 30 minutes. And then we got delayed. Sorry, did you say something? And then we got delayed imaging to look at the ventricles. The ventricles all were stable over time. For me, I really worry about even if you get a nice, a reasonable packing result like this, you're packing against thrombus. And I think over time, these coils will migrate up into the aneurysm. So once we had obtained some follow-up and follow-up imaging and her ventricles were stable and her headaches resolved and her symptoms resolved, then I started her on aspirin and Plavix, and we placed a flow diverting stent pretty much, and this is also probably about a 20-minute case. We placed a flow diverting stent starting just beyond the ophthalmic to just before the choroidal. So we covered all 1, 2, 3, 4 of these other aneurysms. You can see here. So here's the this is like a 4x16 or a 4x14. So a small short pipeline. Here's the ophthalmic. Here's the choroidal. This is her on follow-up. These are all follow-up images down the road. She's at about 4 years now, and I saw her back just recently. She had follow-up imaging. She's doing great. You can see all these other aneurysms are now gone on this follow-up imaging. So the vessel has completely reconstructed over time, and even the little other bumps have gone away. She recently got an MRI, MRA, which also looks stable. Her ventricles have all stayed the same size.
Very nice angiographic result and clinical result. Ophthalmic artery state patent, yeah? I guess there must be a need for it.
That's right, and we also started the pipeline just beyond the ophthalmic. So, this was a nice situation where, we placed just a tiny pipeline in between the choroidal and the ophthalmic, and didn't have to worry about the ophthalmic. But we wrote a paper on it. We've looked at that as well, and I imagine there would be competitive flow into the ophthalmic, and that would have stayed patent if we needed to cover it.
Very nice. Where is Aaron's daughter? Maybe she can start playing with your son in here.
I know, we need to get them running around.
We're right here. We're still watching you guys.
Any comments from the panelists before we ask Babu Welch to share his slides?
I have a question. If this patient was the same picture, but she was 42-year-old and neurologically had some visual deficit and the same hemorrhage I described, no comorbidity. Bobby, what would you have done if that was the case? Would have done the same thing or would have approached it differently?
Yeah, I mean, I think it's a different story if they've got visual mass effect with a small area of a bleed, a young, healthy person. I think as some of the other panelists was saying, a bypass, probably a radial bypass with trapping would be a pretty reasonable option. You'd be able to address the mass effect, not worry about her hydrocephalus down the road. You've got that added benefit of a cavernous ophthalmic, so you don't even need to worry about the ophthalmic artery. You'd be able to put a clip distal to the ophthalmic and take care of the whole segment. I'm sure there are some endovascular folks that would still lean towards flow diversion or coils.
So at 42-year-old and with no major comorbidity, you would have suggested surgical options, correct? Bypass.
I probably would have leaned towards bypass and potentially trapping.
And Giuseppe, do you on the same page?
I think I would have done the same thing. Same thing. I mean, you cannot, you achieved a beautiful clinical and angiographic result in a much higher risk situation than the one you would have in a 42-year-old. So I don't see any reason why doing anything different.
Good point.
And the issue of if, let's say the patient is 42 and has optic nerve dysfunction, yeah, I would have done the same thing, because the results are not that much dissimilar, and there is no question that it's a formidable lesion.
Giuseppe, how about the rapidity of the visual loss? I mean, I personally use that as not an excuse, but as a justification.
Yeah, that is a very important point I want to mention. You know, one thing, you have somebody who has visual loss and ipsilateral atrophy, then no matter what you do, you're not recuperating. The case you are describing, most likely the patient does not have atrophy yet, and that changes.
Right.
Yeah, I think that's a really important point. Those people that have the rapid decline in vision make me extremely nervous. You know, we had a patient like that not long ago, rapid decline in vision, almost the same exact aneurysm. We admitted her on Friday evening, and she bled that night.
Yeah,
pretty terrible case. But we were talking about, you know, doing suction decompression and clipping it. We did an angiogram that evening. She had a hemorrhage.
Yeah, Jack and Bobby, the case that we are describing now, it's a classic unstable aneurysm, and the ones that were a little bit older, we all have had one case where we did the bypass the night before, planning closing the vessel the following day, and that patient, because when they are unstable and they are rapidly symptomatic, it's a giant aneurysm. It's a very unstable situation.
Yeah, so maybe for the people that are listening in, if you were thinking about doing that endovascularly, if there's rapid decline in vision, I would be very worried about just the pipeline alone. You know, if their vision is, if there's some instability of the aneurysm and you don't do something to protect the aneurysm, I think pipeline alone would make me worried about a bleed or, you know, worsening problems from mass effect.
Okay, let's ask Babu Welch to bring it home with the panelists.
Always a little hard to follow such a group, but again, I appreciate being asked to participate here. So let me see if I've got the right. That's the right one, correct?
Yeah. Yes, Babu. Before you just, why don't you tell a little bit the people, like the CV section? What do you have plans? Virtual meeting?
Absolutely. Well,
just maybe.
Thanks for the opportunity. Yeah, the CV section this year has been challenged by COVID from many different directions, and this was, of course, the first year that we've decided to move back in with the endovascular group. So CV section and SNIS are together, August 4th through the 7th. We actually have an excellent session that's new that I think we benefited from COVID from. That's called Sessions with Sages, because I think we're all pretty wise, but all of us could be better than masters, right? So, and those we've paired more senior surgeons with more dedicated endovascular people to work together. Jacques is participating in that, and he's working with AJ Waklu on one session and a couple other. We've actually oversold, so we had to open up and have more participants, which is really great. But I think what's really interesting about the meeting is that we will now probably have the largest international contingent. So I see a lot of the folk on the group, but you have to guess that from a virtual standpoint, now a lot more people can come. And frankly, I expect a lot more people to participate and interact. So August 4th through 7th, registering through the CV section or the SNIS website. And it's actually a little cheaper because you don't have to travel and we don't have to pay for hotels. So everybody who's in CV section and hasn't registered, you're gonna get a letter tomorrow. And if you can think about it, we appreciate it. So I appreciate the opportunity.
Sure.
Tell
us about your case. Thank you, Babu.
Yeah, I call this a periophthalmic evolution because as a dual trained neurosurgeon who does like to operate, as I think we've seen, there's a lot to be said about flow diversion, and that's changed the practice. We at UT, we kind of talk about the fun factor, which case is more fun. And then we also have to pay attention to the training. I think that's been alluded to a few times. And so I think it's, it's fair to consider some training possibilities when you have true equipoise, but frankly, with flow diversion and the results that we're getting, the case where there's true equipoise, I think is becoming rarer and rarer. So we are seeing, just like we, half the reason I went in endovascular is because of, we knew that we were going to be the surgeons who were going to be taking care of very complex aneurysms, and looks like I'm going to show the easiest one. So, but this is, since we can't travel anymore, this is UT Southwestern. This is our campus all the way from this building here all the way back to these buildings here. This is Zale Lipsche University Hospital. That's where that's our neuro rehab hospital that we will be moving from. In January, we'll move to a building that's right down next to this one that's been built onto the new Clements Hospital. So we're looking forward to being closer to the rest of our colleagues. But I'm not looking forward to my office being in the same different building. This is a 64-year-old female who, and I said this is an older case for a reason, but she slipped at school. She's an assistant principal, and she fell at school and hit her head, went to the school nurse, and because she had headaches, they sent her to the emergency room and did a scan. So no pre-existing headache. There seemed to be some trauma. She denied any visual changes or really other focal deficits at all. She had some back surgery previously, and I'll kind of scroll through here. So what they found was this, as we talked about for the topic, parathalamic aneurysm. That's irregular, and it's a little bit difficult to appreciate how this aneurysm is. So I'll include a reconstruction of this. So there's our more looking down on the aneurysm view. You can see the proximal carotid coming into it. So it's really got more of a fusiform component to it. And I think one of the things that we lose as we become more endovascular is really, I think pretty much everybody on this call who's been in the head and outside the head can guess that there's, this term of segmental disease that I've started to use with endovascular therapy, and especially flow diversion, really fits here. But what does that mean in terms of how the aneurysm looks? So again, unruptured, no visual changes, Jorge. So and the focal deficit is really not much. She's got some lumbar surgery that she's had in the past and some leg pain, and she's hypertensive with and controlled on medications. So I think we went through kind of the surgical endovascular options that were available at the time. This was about, I want to say about 2000, so maybe about 10 years ago. That was when we had Pipeline Classic, not Pipeline Flex. So, and I guess a comment to one of the ways we adopted flow diversion here in a different way that I guess in a lot of places we kind of were looking at flow diversion for the aneurysms that we thought were more complicated for surgery. So we weren't doing flow diversion on the smaller proximal ophthalmic aneurysms. We were doing it on the larger ones, and I think that might have been not right. From a learning curve standpoint, it definitely with our lady affected my decision here. So we went through. We had these discussions, and at that time I decided that we were going to do surgical clipping. I think we've alluded towards extradural clinodectomies. And typically here we don't, if I can see the carotid, I'm not going to open the neck right away. I can usually control it, and we can get in pretty quick if we need to, but we're exposing and having prep to know where we're going to go. So again, I can flip back to our movie here and see if there's any comments on things to do different in this day and age. Would this be just a slam dunk flow diversion for most people at this point? Or would Jorge or Amir, would you guys still be taking this study? What's that?
An angiogram?
So, I don't. Probably since about 2006 or so, I do so much reconstruction that I tend to do a lot. If I'm headed towards endovascular therapy, obviously I'm going to get the best angio I've got, and I do a lot of CTA. I think there are rare cases where I'll do an angio, just before, but more times than not, really, since I think about 2006 was our transition point where we were doing more CTA than angio preoperatively.
For this aneurysm, I mean, I do operate on CTA very often, subarachnoid hemorrhage patient, but paraophthalmic, I think, looking at the collateral circulation and looking exactly I mean, you can see probably the origin of the ophthalmic pretty well, but I think that's one that I would like to see. As much as I'm comfortable operating on CTA alone, that's one that I would like to see also an angiogram before a potential surgery. But yeah, that would be my comment. Now, so what you're saying is that because of the fact that at that time you were not doing a flow diverter for this small aneurysm, so that was the option was out. And
yeah, and and we had I think our experience was growing, and frankly, I've got the way we were pretty heavily surgically bent at the time, so I think those are probably a few things that kind of weighed into the decision. To your comment about the CTA, for me, and if this patient showed up with an MRA, for the paraophthalmics, I will always get a CTA because I want to know what the clinoid looks like, the bony anatomy, how it's related. But obviously with an MRA, if you get a contrast one, especially, you get a better idea about where the ophthalmic is sometimes than with the CTA because of the bone.
Absolutely, CTA is absolutely important. I will definitely have the CTA, but I think angiogram is also helpful. It seems that you need to have, based on that rotation, that you need to definitely have an anterior clinoidectomy. For aneurysms, I usually do them always intradural because it's not always necessary to remove the whole clinoid. And I like to see the aneurysm when I drill, as opposed to if I do it for anterior clinoid meningioma that I do extradural. And in this case, absolutely needed. And it seems that it's a medially projecting aneurysm, correct?
Well, that's it. I think there's a lobe to it. You can see if we look right there, it's more posterior. There's probably a more medialized lobe, I would say. But more if you look at it right down the barrel, the distal aneurysm comes out here, proximal's there. You can see there's a ligament there. It's not calcified, so clinoid's here, posterior clinoid comes in, but there's space there.
Seems that after clinoidectomy, definitely open the distal dural ring, and the best way to reconstruct this aneurysm would be with the right angle fenestrated clip that goes behind and reconstruct the lumen around the carotid. And I would definitely do that with an intraoperative angiogram.
Yeah.
And one other comment is that we now, I mean, not at the time that you did the surgery, but for all of these cases, we don't open the neck anymore. We do in balloon occlusion if needed in the Ziegler room. So that will avoid the incision in the neck.
Yeah.
So now a series of these that we just put a balloon up with a cello balloon in the neck, and then whenever we need, we just dilate, and we can actually suction decompress as well if we need so.
Right. Yeah, we built the first hybrid room about 7 years ago, and there's no question you had to kind of convince us to do that. But even my senior partners here will be in there with the balloon, either a flow gate or a cello, and for suction decompression and for occlusion. There's been a lot of discussion about heparinized saline or not, when you've got an indwelling catheter, but so yeah.
I've never had any problem. So just also as an additional comment, that has always been a sort of a resistance from some of my endovascular colleagues to give heparin, but fortunately we never had any issue with heparinization of intravascular balloon during open craniotomy for aneurysm. Not so.
Yeah, I tend to agree with you. The amount that's put through there, we've even checked ACTs. There's been a slight bump in ACTs when we're in there with a with a low drip through that flow catheter, but I think only one of us at this point probably just uses saline. The rest of us will use heparin when we're doing that.
Babu, just for the sake of time, just take
Sure.
us what you did so I leave time for questions.
Sure. So surgical clipping, extradural, we talked about going through, and this is where I think, frankly, it's kind of artsy. I like the way that the aneurysm looked. This is the extradural clinoidectomy, just kind of running through that. And again, Amir, I have kind of graduated towards the extradurals for the aneurysms, just because I think I can be a little bit more aggressive with it, especially if I think they're involving or going into the clinoid. I do that. I like to use a round knife to kind of get into the ring. So this is kind of opening things up. You can see the the optic nerve is kind of slightly medially displaced, but not horribly. And there's our proximal control coming around that way. So there was enough proximally to get around and get control as necessary. But you can see this wasn't kind of the just a little something coming off the aneurysm. Giuseppe, I refer to this as my Murano aneurysm. So, but because it really is just, it looks like somebody just tore the carotid and left the adventitia. Don't ask me what I was doing with this ruler, but this is kind of what we looked at. So, you know, this is what, you know, we don't see that anymore as much. And I agree that, you know, in this day and age, I might have considered flow diversion, but you know, if we look at that now and we see this completely useless segment of aneurysm, you know, is this something that we're coiling when we flow divert? Is this something that we're just flow diverting? Because, you know, I think most of us would just put a flow diverter down the middle of that. But I didn't see a really solid way to just put a clip and trust the rest of the aneurysm, because this is our circumferential involvement. So what we did was we did place a clip just proximally. The choroidal was, see, is right there. And I'll pause here. But the choroidal right here, placing a clip here and being able to work with the clips, I think was going to be hard. So you saw I placed it, but I removed it. And I actually wrapped this aneurysm, but I don't like to, you know, wrap aneurysms, just put muslin around. To me, a wrap is a wrap if it is circumferential, and then we can actually, you know, strengthen it with the clips. And there are goods and bads to this, and we'll see this on the angiogram. Look at the stenosis that's here, and same thing that we saw on the front end of the aneurysm. But what you're seeing here is just kind of, this is the HemoShield patch that I like to use. I know Gore-Tex is espoused at times, but when you talk to, the whole reason Gore-Tex works is because it's not adhesive. So you really don't scar Gore-Tex. And I think if we're looking for something from scarring, we do that. So what we ended up with at the end of things was kind of that clip wrap. You know, I think when we're placing coils, and again, in deference to Jorge, around the nerve, we have to really be careful about those, clips. Have to be careful about where the clips are next to the nerve. And there's still a little bit of a pooch there where the bipolar is. And so another wrap was able to be placed around there. And just with a little bit of cotton down at the base and Surgicel, it pulled everything away from the nerve, and you can see the nerve itself is, you know, relaxed away from the aneurysm. So the point here to mention, I mean, this was a kind of I did not expect to see that anatomy. I expected to go in there and mirror like you were talking about and put a clip on it and make it look right, but that wasn't really the possibility. I did a post-op angio. You can see there's a little bit of this kind of doubled over tissue, but I know that's inside the clip, and a later angiogram did show that. I think Jorge showed his, that little area just kind of remodels and seals off. It's stenosed, but still good flow distally. We did a perfusion imaging to kind of make sure that I hadn't stenosed it too much. I think one of the concepts for wrapping or clipping these fusiform aneurysms is, you know, it's ugly on the outside is probably a little bit better. So I think that's about as much as I could push it. And you know, I would say, you know, if I would do this today, if the patient did not rupture, I think if the patient had no contraindication standard platelets, if there wasn't a history of chronic headache, I think, and there was no acute worsening of nerve symptoms, I think this would have been a flow diverter case. But I do agree with the group. I think we look and, you know, we lose some of the fun anatomy, we lose some of the thought processes when we go in, and we also lose our trainees when we start talking about when we are flow diverting. So I think, you know, for me, what I really like about, you know, working with the group I work with is we sit, we talk, we decide just like this group did, and make decisions about aneurysms that are long term, but you know, but with an eye towards education, because that's where we all are. So that's fast enough for you?
That's great, Babu. Thank you so much.
Mm-hmm.
Okay, so is Carolina, I don't know if Carolina had to leave. Hey, Carolina, you want to help me with some of those Q&As? Or I can, you're muted.
There we go.
Hey, how are you?
Good. How are you?
Good.
Okay, we have a lot of questions from the audience. So
I know. We'll try to cover. Yeah, go ahead. I'll keep you in charge.
Okay. So one of the questions is, and I guess this is for any of the panelists really, how and why does the anatomy or location of the aneurysm affect the treatment choice, which we discussed to some degree, but I don't know if somebody has anything else to add to that. We've kind of discussed that along the way as the panelists gave their examples.
Yeah. So guys, so if we can, if you don't have specific comments to a question, I think we'll just, you don't have to comment every time, so we can cover most of what has been asked. So whatever, Carol, yeah, go ahead.
All right, and then I guess I'll pose this one to Bobby. Is it possible to use the flow diverter in acute stroke and in ruptured aneurysms?
So ruptured aneurysms, the answer is yes, although, we always worry about how we're going to deal with a potential shunt. We've written some papers looking at how to manage the shunts, how to deal with the aspirin, Plavix, or other anticoagulants. So it's possible, but you've got to have a good plan for dealing with EVD, shunts, all those things. I tend to be pretty aggressive about putting an EVD in up front if, we're really going to go down that route. And I often will also use, coils potentially with flow diversion. Now, those are usually for pretty complicated cases that don't have another good option. Acute stroke, I assume they mean acute stroke, meaning an acute bleed. But I guess not sure I understand the second part.
Yeah, that was
probably
with a bleed. I'll ask this question to Dr. Mura. Great, excellent talks. But what would you mentioned not using the drill for the clinoidectomy? Somebody was asking about the bone scalpel, if you've used that.
Yeah, I use that, but the bone scalpel heating as well is the same. Yeah. I rather prefer to do rongers. In aneurysms, you don't have the hyperostotic bone. When you have a meningioma, for example, of the clinoid, you need to, but we drill only to put a small amount of bone over the optic nerve, and we finish the surgery with rongers all the time. I learned that because when I came from Brazil in 1999, in my hospital, we don't have drill. And then I need to do the surgery, and the drill came in 2002. And then I was used to use without drill, Latin America. And but now I try to use for example, the Sonopet as well, but the heating is the same. And then I only use when I don't want to have danger, for example, for lesions in the, the anterior petrosectomy, that kind of things, But for aneurysms, I always use the rongers, no problem.
Somebody asked a follow-up question about open surgery as well. What is your opinion on doing these surgeries awake to minimize risk of ischemic event?
I think I don't agree with the do awake surgery in vascular surgery, because I rather prefer to use monitoring, motor or monitoring and sensory monitoring, cranial nerves, and it's very good. I know that in St. Louis they like to do the awake surgery even for bypass, but I don't think that a patient is going to take it. Of course they publish, but for my practice, I think we have enough tools to get for a safe surgery.
Okay. Dr. Lenzino, we have a question here from Costa Rica, Dr. Sanchez. How come thrombosed aneurysms practically disappear after treatment with flow diversion, but don't shrink as much after clipping or parent artery ligation?
Well, that's a good question, and it's important to consider that the aneurysm after flow diversion shrinks as long as the wall is not calcified, because if the wall is calcified, then the ability to shrink is fairly limited. And some aneurysms, the aneurysm after flow diversion, they shrink because the thrombus that forms after flow diversion, it's an acute thrombus. And you have, over time, you exclude the aneurysm from the circulation, while after parent artery occlusion, the aneurysm that is already has thrombus in it, then the thrombus is more established. I don't know if that was, I think, the sense of the question. So that's the difference, probably. How acute is the clot and after flow diversion? Unless if you treat with flow diversion an aneurysm that has established and organized thrombus, that aneurysm might shrink, but only partially too.
Okay. Actually, Amir, maybe, hi, how are you? Maybe you can answer this. Somebody was asking if you have experience using the flow diverter in skull-based tumor cases with vascular encasement in order to reinforce the arterial wall.
Before the surgery, you mean?
Right.
Yeah, that's probably what they mean, yeah.
Yes. No, but I have experience with using because the problem with the flow diverter using before the surgery, unless if you space it at least to 3 to 6 months, is that you have to stay on antiplatelets. But I have 2 cases of a very complex anterior skull-based or clinoidal segment meningioma, not for the sake of protection of carotid artery. That has not been my indication. But those carotid arteries, interestingly, they both had fusiform aneurysm extending from cavernous sinus to the supraclinoid. And one of them actually during the surgery at the last part of the removal bled, and I was able to get it under control. But both of those patients got a stent, one stent, a usual stent, and the other one flow diverter months after surgery for meningioma. So this is a combination treatment that we can do, but I have never done it before the surgery because most of the time those patients need surgery sooner than later, and a flow diverter would be almost a, almost a relative or to absolute contraindication for immediate complex intracranial surgery.
Several years ago. Oh, go ahead.
No, I would say not flow diverters, but I mean, we work with the ENT surgeons here for the carotids and covered stents.
Exactly.
And covered stents in the carotid, if you think about it ahead of time, covered stent actually does pretty well, and we've got a nice, early experience using that. And they're a little less hesitant to operate on dual antiplatelets than we are in the neck. So that gives you a little bit lower, a little bit shorter window that you have to work in. And frankly, with the newer catheters, our ability to get covered stents to different places in the skull base is much better than it used to be. So I think covered stents probably more than flow diverters because they tend to really exclude the circulation, not rely on thrombosis. So.
Yeah, we actually place covered stents really quite often for a lot of these giant neck tumors, and it's amazing. You can actually cut down right on top of the stent with no bleeding whatsoever. We've also used them for giant carotid body tumors.
Right.
And you basically see all those small branches that are feeding the tumor disappear. You're left with a nice lumen, and you can cut straight down on top of the stent without a problem. The ENT, they like to send us these beautiful pictures of looking straight at the stent in their cavity.
Okay. How long do you leave the antiplatelets on for?
Those stents, a lot more coverage, as you know, and I think they have a much higher rate of thrombosis. So I like to keep them on longer term aspirin and Plavix. We've had a couple cases where we had to stop Plavix at 6 weeks, but I'd rather aspirin for life and Plavix for 6 months.
Yeah. I think that's the difference, though, is where we're operating or where they're operating versus us.
Yeah, in the brain, a whole nother story operating on aspirin, Plavix, and.
Right.
I guess another realm of ENT tangential questions for anyone, but what do you think about the transsphenoidal endoscopic approach for clipping of paraclinoid aneurysms?
Dr. Mura, you keep looking for a smaller way to clip aneurysms. That's the ultimate. Why not do it through the nose like our good friend in Pittsburgh, who was our speaker 2 weeks ago?
I think that the size is not the problem. I think for me, in some way, I'm a purist in the follow of the principles of the vascular surgery: the proximal control, distal control, and exposure of the structures.
Sorry to interrupt you. It's excellent control from the cavernous carotid. Actually, better control almost than when we do a clinoidectomy.
The problem here is the instrumentation.
Yes.
You see the instrumentation in order to have the proper clip, the proper applier, and the closing, the fistula. What happened if you had a remnant of something? You had the clip with the flap. I think the limitation of the endoscopic approach are the instrumentation. You know, we talk about the patient, the team, and the instrumentation. Here, the instrumentation is not good. Even we know that we have very skilled surgeons from the nose, but the problem today, up to date, the clips, the appliers, and the closure, I think is not very good for this kind of surgery.
Leaves a lot of room for innovation, like you mentioned.
Yep.
I think the paraclinoid ones, they're pointing up, so an endoscopic approach is really tough. The ones that I think are really difficult for any approach are probably the mid-basilar segment ones. I mean, we don't have a great answer for those either surgically or endovascularly, and potentially with a long clip applier. I think Dr. Gardner showed some really nice cases.
I think that
those ones.
That is good for endoscopic endonasal. As much as I like endoscopic endonasal surgery, I think there's no reason to do any aneurysm clipping except for small carotid cave aneurysm. That's the aneurysm that will be best visualized by endoscopic. But, you know, that's arguable. And I think it's extremely debatable to indicate an aneurysm surgery endoscopic endonasally. But that would be the choice for that approach, in my opinion.
Carolina, how about 3 more minutes of question and then we'll finish. You select what else to go for.
Okay. Someone's asking, maybe Dr. Lenzino, when using a balloon catheter like cello, do you use a bolus of heparin or just heparinized saline throughout the lumen?
No, I would use heparinized saline, and I think I agree with the comments that have been made before that once you have everything exposed, you have done your craniotomy, the heparin doesn't add a lot of problems, but I would use heparinized saline rather than giving a bolus in that situation.
And then someone also asked if the treatment elected is flow diversion, is anticoagulation a problem in young women? I'm not sure where they were going with that question. They didn't explain any further. Perhaps maybe with the dual antiplatelet, but I don't think that tends to be any issue from that standpoint.
Correct. I don't think it's an issue. And for paraclinoid aneurysms, the antiplatelet treatment is really not necessary for life. Mm-hmm. We do dual antiplatelet for 3 months. For paraclinoid, after 3 months, we stop the Plavix, and we tell the patients to keep taking a baby aspirin, and many, after a few months, they even stop even that. So.
And maybe they meant about pregnancy. Is patients who are planning to become pregnant very soon, is that could that be a contraindication for?
I think there's two places where it's come up for me in my practice. Is one infertility, and steroids and implantation and things like that. That's coming close. Antiplatelet therapy, they want to kind of know about it. And I do ask about heavy periods, right? I've had patients who have gone to the hospital because they're having really heavy periods and they have to be transfused. So, you know, if that is a concern, then that has in a couple of instances come to be a contraindication to antiplatelet, because we, like Giuseppe said, we think 3 months is going to be fine, right? But once it's in, then if it's 3 to 6 months, then, you know, that can be an issue. So I ask, but is it common? It's rare. It's usually, frankly, last person I can remember was an older patient who ended up having ovarian tumors. So yeah.
Yeah, Plavix is a class B teratogen, so very low risk of causing a pregnancy problem, but limited experience. So usually we tell patients, you know, they're going to be on Plavix for a short period of time, 3 to 6 months. I agree that GI hemorrhage is definitely a very relevant factor. We've had lots of older patients where we would favor an endovascular approach, but dual antiplatelets and history of GI bleeding makes that challenging.
I guess one final question, we can sort of take a poll. Somebody just asked, and this has been addressed multiple times, but would visual impairment, should that always be an indication for microsurgery? Bobby, you want to start?
No, I mean, I think that the PUFS trial, and there was actually a publication from the PUFS trial directly on patients that have visual impairment. And so for certain cases, still vision can improve with flow diversion and thrombosis, but I think it has to be carefully assessed on a case-by-case basis.
Dr. Welch?
You know, I think decompression of the optic nerve on antiplatelets is not good. So, you know, acute worsening in a larger aneurysm, like a few of the ones that we've shown, it's just, you just kind of sit there and watch, and that's not nice. So, yeah, I agree with Bobby, case by case, but the larger aneurysms that have a preoperative, I usually get preoperative visual fields. If there's already a defect, that may lean me towards surgery. So,
Dr. Lenzino?
Yeah, I agree with all the comments that they've made, but I don't think that the presence of a visual deficit per se, it's a definite indication for microsurgery. That flow diversion would be an option, but it depends on the specific case.
Amir?
I think the short answer to that question is no, there should not be a contraindication, but I do favor surgery if there is in the right setting for those who have visual deficit, specifically acute, no question. But the short answer to your question is no.
Dr. Mura, endovascular always?
Microsurgery. Always.
He needs more clinoids for his bottle of collected.
Yes, I have my
fiber.
bottle with more than 300. But now the problem, the fellow take the clinoid, then it's not mine anymore.
Aaron, you have the last word before I say goodbye to everybody. Unmute yourself and give us some wisdom.
You know, I think the question that was raised is that because we're doing so much endovascular work, which is the future, we're going to have less and less expertise to manage complex aneurysms that have no choice but clip ligation and microsurgery. I think that has become sort of a very big reason why people say, well, we have to do more microsurgery just because we want to train people to be able to do those small aneurysms. That, unfortunately, is not a perfect reason because most of these aneurysms have to be done by those few centers of excellence to have good outcome. We're not going to have, every big city have multiple people doing microsurgery for aneurysms in the future. There's going to be very, very few select people, and people who want to continue that art is very important to train in those few very select centers of excellence. And there's plenty of microsurgery. Believe me, there is so much microsurgery we do every day that we can keep our art alive, very strong, and the journey is long, and the beautiful art of microsurgery that all of us enjoy so much has amazing horizon and amazing future. So just because most of the paraclinoid aneurysms, almost 95% are going to be endovascularly treated, we don't have to be too worried about it. There is absolutely plenty of opportunities for great microsurgeons to demonstrate their superiority.
By the way, you talk about decentralizing microsurgery. To be honest, the bigger problem is decentralizing endovascular.
Correct.
People on this panel are thoughtful experts. There are lots of not such good work being done by little shops of endovascular around the country. And that's where the danger is really. It's not a danger to have a Giuseppe Lenzino or a Bobby Starke, coiling aneurysm, because they know what they're doing, they're thoughtful about it, but that's what's going on.
Right, but I was more focusing on centralizing, not decentralizing.
Yeah.
I agree that there are cardiologists who are putting flow diverters, there are people who don't have the good training, but putting those aside, I think there's huge opportunity and a very bright future for great microsurgeons to continue to demonstrate their excellent techniques.
Well, on this note, this panel has officially broken the record of length of session. It's 7:36 p.m. Quality and quantity. I'd like to thank you all for the wonderful presentations, discussions. I thank the audience for sticking with us, that we started in the 300s and we lost several, of course, as normally happens. Good night, good morning, everybody. Bye-bye.
Thank you, Jacques.
Thank you.
Good to see everybody.
You, sir.
Bye, have a good one.
Thanks, Ignacio.
Ciao, ciao, que esté bien, compatriota.
Bye.
Viva Chile.
Viva Chile.
Bye. Thanks.
Bye-bye.